Hello. In this talk, I'm going to explain more about some of the concepts and principles of working with children with spinal cord injury rather than the more mechanical aspects of the previous talk. So what do we need to do with a child or with children who have spinal cord injury? We're used to the concept of rehabilitation, and that's the process of restoring a part of the body or the person to as near as normal function, putting them back on the trajectory that they should have been on if the illness or injury didn't happen. But for children, this is about habilitation. It's the highest achievement a person can achieve with their own personal qualities, and it's remembering the child is often learning brand new skills. It's not about learning to walk again if you've never actually walked in the first place. And essentially what our role is to make sure that the child and the family be the best they possibly can be, both physically, emotionally and socially. So where do we start? Like most things in medicine, it's right at the beginning with the principles of Heidi. It's the history, making sure that the history fits with what the child actually is presenting with us today, examination of the general health as well as the neurological system, investigation, MRIs, long spines, etc., formulating the diagnosis, and from that the rehabilitation plan for what age the child is now, as well as what we're thinking about doing in anticipation for the future. We tend to all start with our own uni-professional assessments, and that can involve as many people as you require for the needs of that particular child. At times it may involve the oncologist or the orthopaedic surgeon. Once all those particular assessments are gathered together, we then sort of look at how we're going to work together around the child. We also need to involve the thoughts, feelings and sort of ideas of the family, the child themselves. And one way of doing that is using the child's needs assessment checklist, which feeds into goal planning for children. This multidisciplinary planning started off in the adult world and was a successful tool to establish patient independence after spinal cord injury, so that irrespective of the level of injury, people could be independent in looking after their healthcare needs, and that could be either verbal or physical. The team members that use the Child Needs Assessment Checklist is an indicator of participation in rehabilitation, and often a way of actually looking at what the high points are and also what the difficulties are. There has been a lot of work on testing validity, and that has been shown initially the adult one wasn't suitable for children, therefore we had to do some alteration for children and young people. So we use the child one for under 16 and the adult for those 16 years and above. Child's Needs Assessment Checklist is quite complicated to document at the moment, and we're looking at ways of updating it. Very much it's about all the different members of the team around the child. It's administered by a key worker, and specific key worker training is undertaken. It is a long document. It does need time to actually work with the child and the family to make sure that they're aware of what it is that they can participate in particular. And it plans the goals for the rehabilitation and to get engagement and participation. The areas that are very much looked at were a reflection of what we actually do in clinical practice. With physical health care, activities of daily living, skin management, bladder, bowel, knowledge of the spine and promoting healthy growth, mobility, wheelchair and equipment, community and education, and discharge coordination. Very much what we're looking at is what specific goals do the children want to tell us about. And the opportunities for telling us can be in a variety of ways. It can be verbal, it can be drawing, it can be just talking. And again, it's about making sure that the needs of a 2-year-old and a 4-year-old and a 6-year-old will be completely different from a 14-year-old, etc. It's about allowing that flexibility to get the best out of the rehab process. Physical health involves a lot of things which are quite often done, like height and weight, the diet, understanding spinal cord injury, making sure that we're not using jargon. Things which have been sort of left out of previous rehabilitation aspects for children have often been things like pain management and sleep. And we use a lot of visual changes and scales in order to help people work with us on this. And lots of things that we do is based on the feedback that we get from families and the children themselves. And we often do this as part of the workshop. And also one of the things development was of developing a children's scoring system based on minions of how well they felt the whole process is. The specific questions for those with levels above T6 and below. Above T6 in particular, we're looking at autonomic dysreflexia management, respiratory, secretion clearance, and how the child and the family work that one with themselves. And for those who require a ventilator, there's a lot of information about knowledge of equipment, settings, and safety breathing or frog breathing. Lots of these things start off teaching the family and the carers with just a little involvement of the child, but as the child grows, we expect them to become the expert and for there to be a sort of seamless handover of care as you would expect with any child growing up. Skin is also incredibly important in children just as it is in adults. Just because they're smaller doesn't actually spare them from the results of pressure ulcers. And often playing with toys and making sure things like Legos may be cleared up afterwards can prevent a lot of problems. A lot of what we do in the skin is very much based on physically, if possible, seeing what skin check. Mum is usually the person who starts off, and as they age, we would expect the child to be involved or to be able to tell the parent what they need to be looking for. Prevention of pressure ulcers and also prevention of burns are extremely important in young people with spinal cord injury. For bladder management, it's like with adults, we're looking for social continence, but we're also very much looking at making sure that we have a system that grows normally. We want as large a capacity bladder as possible with the lowest pressure as possible, because we want the kidneys and the bladder to grow as healthily as possible and to last a lifetime. Bowel management, just like in adults, is often more difficult to establish in children. We do want social continence at the appropriate age. We do not want children being in nappies for longer than their peers should be. Establishing whether it's a flaccid or upper motor neuron bowel is incredibly important. Trying to establish good dietary habits isn't easy. The pot noodle in this picture didn't particularly help. We do have to use laxative and suppositories appropriately for that particular bowel, but also a lot of the things that we need to look at thinking is, what are we going to do to the lifetime of this bowel? Will it still respond? And so a lot of things we're looking at reducing the amount of suppositories, looking at more transanal irrigation and using water as part of that. But it's equally important as the actual what you do to the bowel itself is what the upper limb involvement and what the self-care. Can you cleanse after emptying? How independent are you, both in your own physical abilities and your environment? What's your house like? And it's very much about getting away from the bed and getting onto the toilet. We have to work on the spine as the previous sort of lecture where we're really concerned about neuromuscular scoliosis. So therefore posture management is a 24-hour programme. We're looking at how we can look not just at the spine but all the other joints to promote growth and development, to try and get the height as close to normal as it should be, to try and get muscle bulk as close to normal as it can be, using stimulation, etc., using standing, using gravity, and orthotics in a very expensive way, but that's what needs to be done. For mobility, we do have to think of the here and now and also as the future. We want to be protecting the shoulders as much as possible, but keeping the child active. So very much whether the child transfers by themselves as they grow, and also we're protecting the parents. Easy to pick up a 2 or 3-year-old, but we do not want the same family picking up the same 10-year-old when it really is unsafe on both child and parent. Children grow, whether it's a pair of shoes that they outgrow, or it's a wheelchair, or all the other forms of equipment, they have to be the right thing at the right time. This involves a programme of making sure that children don't grow out of equipment. Equipment that's grown out of doesn't get used. The child then sort of goes out of postural control. And it is very much about constantly checking that everything's there, everything's in the right position, and it's doing the job that we expect it to do. And it also works. It's a lot to ask the parents to get the child up and dressed in the morning, check the cushion, check the brace, check the splints. It's got to be right. Gone are the days where children are automatically sort of sent to specialist schools. We're very much looking at integrating our children into their communities, whether it's in education, primary, secondary or tertiary. The child's needs for education should be based on their cognitive ability, nothing else. We do need to continue to expand what children want to go into in vocational aspects following education, and there's still issues with that. Driving can occur earlier in our group. At 16 they can start applying for a licence. We've also got to ensure that education opens up to all the aspects that young people want to know about, including sexuality and fertility, and also one of the ways that we've been able to encourage children to fly the nest and to build up a lot of skills is on backup courses throughout the country. For discharge coordination, we still have ongoing issues with many places that we discharge to it being the first child that they've had with spinal cord injury. And there's still a lot of perceptions that the child won't be as active, or we won't be sort of promoting them to go on to normal activities, which by 2021 we would have expected to have moved on with. It is important to make sure that the family have the correct access to finance and the correct house, and that those needs are growing. It's also important to realise we expect this child to move on from the family home, and the house isn't built for them and their family for a lifetime. As I say, we do want them to fly the nest. This often involves changing care package. What a young child may wish the mother to be part of their care is not what a young person 14 or 16 wants. They may be happier with mum being mum for some things and a carer performing intimate care. Again, it's about knowing the child and being able to push on local services or using compensation packages to make sure the right assistance is obtained. There's no right or wrong time for looking at the psychosocial issues, and particularly about sexuality, and there's many different approaches. The main thing is about keeping all areas of communication open, whether it's peer-to-peer support, whether it's recommended websites, whether it's one-to-one teaching, or whether it's just teaching through the schools, but then the school must know about what the children's concerns are before they can appropriately talk. A lot of psychosocial issues may be directly related to injury. Other ones that we see are things like body image, eating disorders, depression and other mental health issues. What can happen in the non-disabled population is equally likely to happen, but sometimes with a more acute focus. Participation and activity are incredibly important to everybody. And one of the things that we've been able to to benefit from is being closely related to the sports education and ability and facilities that are around the hospital. This really does increase children's ideas of what is available to them, but it's important to remember it's not all about sports. It can be about the arts, it can be about travel or languages or whatever it is that the child wants to do. They need to know how to get in touch with and how to continue to do that as they get older and it becomes much more age appropriate areas of recreation. There's many ways of assessing progress through our pathways, assessing progress even through ageing. A lot of it is about looking at how the child themselves views success in life. It's very much about sort of changing negative attitudes, making sure that any areas of discrimination against disability are openly reviewed and the correct challenges are made. The physical successes is very much about looking at how we can improve on life expectancy. The particular group that I'm very concerned about are children on ventilators, as their life expectancy is nowhere near what it could and should be. We've also got a lot of work to do why children are not fully participating in life events following rehabilitation and particularly following education as well. We do want to see reduction in scoliosis surgery, but that has to be the caveat that there will be some children that will always require it. One interesting approach recently has been looking at coming away from the medicalisation of what we do in child rehabilitation and even within the needs assessment, and about using very much child development principles in rehabilitation rather than the normal rehabilitation. A lot of this is based on the ICF framework, and it does fit with goal planning, but sometimes it works easier with a child and their family. Rather than getting into all the domains of rehabilitation, we talk about function, which is our activity, the family-centred care, the environmental factors of who's going to be looking after this child, because they're the ones that are doing it on a 24-hour basis, 365 days of a year, not this sort of very short professional contact that we have. For fitness, we need to look at the body structure and function, friends, participation, fun, personal factors, what makes that child click in the future, that anticipatory care that we need to do. There's a lot of information on the Knowledge Hub of F Words in Rehabilitation, which is of the CAN Child, the Canadian Rehabilitation Research Site. I talked about the young people who are ventilator assisted. Work that has been done back in 2000, but I'd be very happy if it was changed, but I think there's still a lot of things still going on. It's very difficult for young people who are ventilated to have the same rights and responsibilities of people of their same age. We are still trying to make sure that these children are not discriminated against. We found that during COVID it's been far more difficult for them to access care because they're aerosol generators. Sort of casual, let's pop in and see how they're doing, doesn't work as well, when everybody's got to get gowned up and use PPE. These children basically grow up in an adult goldfish bowl, and I think it's one of the things that we need to look at, moving children off ventilators onto phrenic nerve pacing, etc., and allowing them to have a much more normal physical and psychological childhood than we are currently doing. Adolescence is also a very interesting phase for everybody, and particularly those with a chronic disability, of which spinal cord injury fits in this. It's incredibly important that all the things that change in adolescence and makes it a difficult period for anyone are addressed through the spinal cord injury network. Not every spinal unit admits children, but every spinal unit does admit adolescents. A lot of the long-term care is changed from the family to the young person, and it's important that this is done correctly. We know in other conditions that we lose a lot of young people as they move from childhood to adolescence and then into young person's care. And one of the things that we need to review is the clinical services to keep people in the correct follow-up within our spinal cord services. One way of doing this, and I'm sure the next speaker will talk a lot more, is the Ready Steady Go programme based at Southampton, easily again accessible on the web. Important for everyone to know about, because it's not just about taking the young person through adolescence, but it's about accepting that person into adult care as they progress through life. So what next? We've got to get it right about moving children to adult services. We've got to continue to review what the important things are, particularly medically, when we're following up these children, and looking at what we learned when we've got a lot of children to review. A lot of the issues that we see with obesity and eating disorders only sort of come to light when you see a group, a cohort of these children. We always have to look at what the future will be with regards the neuroplasticity of the child's cord, what we're going to get involved with repair and regeneration. It's difficult when we've got very poor ways of assessing how good things at INSCI are and what intervention makes different. And a lot of work that's been done at the moment is about developing shared care pathways between paediatric services and spinal cord injury services, and making sure that no child is disadvantaged purely because of where they live. So thank you very much for your attention, and these will be available on YouTube if anybody wishes to look in more detail. So thank you very much.